Is going to be Dr. Ajay Kirtane.
Thanks so much. That was a great session just before this, and we'll try to continue in this vein with a variety of tips and tricks. And I just want to thank one of my colleagues, Dimitri Kompraliotis, who provided me with some of these images. So I think to start off with, and I'm going to talk not just about crossing, but just managing dissections in general. And remember that dissections can sometimes be intentional, and particularly now when we do more CTOs, some of the techniques that are being used, I mean, the CART technique is a controlled antegrade dissection and reentry, and the reverse CART, more frequently seen, involves controlled dissections. And I know there are talks later about other types of devices, such as the Bridgepoint device, which is actually a way of causing a dissection plane. And for those of us that do peripheral interventions, this is a commonly employed technique to cross total occlusions in the periphery. So we often will deal with dissections, sometimes big ones, in that arena as well. But also we should think about dissections that are unintentional, unintended, or accidental. And these are the cases that all of a sudden they're calm and then they're not calm, and we need to know how to be able to deal with these. And so hopefully I can take you through a few examples. So this is just an example of a complex right coronary artery. There was a fair amount of disease, and so the operator elected to treat this, but using an Amplatz guide. And so this is an example of the Amplatz guide. And immediately what can be recognized here is that there is a proximal dissection. And so often when we're doing interventions, we are focused on the lesion. And we don't look at things like flow, we don't look at things like guide, we don't look at distal wire position. And those things are really fundamental when to avoid distal perforations and guide dissections. And here you clearly see there's a guide dissection. So the question is, what should be done at this point? And so there are a few things that should be done. The first is absolutely you cannot lose the distal wire. Number two is you want to stent this quickly. You don't allow this to persist and stain and anything else. Even though it's harder to deliver stents through an existing stent, this needs to be dealt with immediately so it does not extend either proximally or distally. So that's important. And the third thing you don't want to do is you definitely don't want to keep injecting, because the more you inject, particularly with a guide in this position, the more this will spread, because you're causing a hydraulic effect. Now, if you see this picture here, you can see there's several things that have happened that I said you shouldn't do. One is the wire has been lost. Two, the operator continues to inject. And as you see the operator continue to inject, this lumen becomes more and more faint, and what's happening is there's a hydraulic effect of the injections that's extending the subintimal space here. So this was then attempted to be wired, and it often happens here. It's difficult to get the wire in the right place and the right way, and the operator continues to inject. I think for those of us who have been in this situation, unfortunately, when you're advancing a wire, if it's not going, you don't need to inject to tell yourself that it's not going. You know it's not in the right place, and injection is not going to help you figure out what the right plane is for it to take. Again, here's another example, contralateral view. Good idea to take a different view to see where you're going, but don't inject, because the more you inject, the bigger the dissection plane is getting. So what you're trying to help yourself, you're actually hurting yourself in the long run. You can see the balloon pump has been placed in the meanwhile. So what actually occurred in this case is this was the use of the Bridgepoint device, or actually the Stingray, which is basically a balloon that self-centers in the subintimal space and has holes on either side, which can then, you can come through and puncture and out of the subintimal place into the actual vessel. And here's an example of that. You'll see the wire come out, and then after it finds the true place, then a distal wire is advanced, and then it can be successfully stented. This is a use of a guide liner down here to facilitate delivery of the stents as well. And at the end of the case, you have to stent all this way. You've lost marginal branches, but at least you've salvaged the patient and not had an acute MI. Now I'll take you on another case. This is actually a case that illustrates a different point. This was a patient that I actually treated a couple weeks ago who had a CTO of the left renal. The right renal was patent, but preserved renal function, and actually an MRA demonstrated not only a normal size but normal perfusion of the kidney. So this was actually approached via radial from above, and then what is called a morph catheter from below, because of a lot of iliac tortuosity. And so in this case, we were able to localize this based upon the MRA, and actually wired this first with the Fielder XT, and then with a Miracle 6 wire, which then passed freely over here. There was quite a difficult time getting the wire through this segment, as seen here. Actually, after this, balloon angioplasty was performed, and the next picture here, you see there's a huge dissection extending from the aorta into the renal artery, which is presumably how we were able to recanalize the CTO. So the question is, what should be done at this point? And so what I would say, another fundamental rule is that, again, you don't keep injecting, which will extend the dissection, but what you want to do is you want to visualize this with something else. And so in this case, we actually performed IVUS to determine where we were in the true lumen and where we were in the false lumen. And so this is the example of the IVUS run that you'll see. Basically, in the IVUS here, here's the catheter, here's wire artifact here. And what you will start to see is a huge subintimal hematoma here, but the wire is still in the vessel itself, and this is a subintimal hematoma. And then as the IVUS extends back further, you'll actually see now we're in the subintimal space and the vessel is up here. So we're outside of the vessel itself, but we're in the subintimal space. So this IVUS was very useful because it shows you that you're obviously in the aorta with the guide, then you're subintimal in this big hematoma, and then distally you're in the true lumen. If you're not in the true lumen distally, you cannot stent. I mean, you can try to, but you're going to extend things and you may not get a good distal purchase. On the other hand, if you're approximately true distally, you can then try to put a stent in, which is actually what we did in this case, and the patient has normal filling. There's still residual dissection here, but actually the patient's creatinine normalized and the blood pressure is now at a week out under control. This is a case of a right coronary artery, again, complex CTO type of case, and what you'll see the operator do here is that the wire gets in the wrong place and injections are undertaken, which is fine at this point, but now when the wire doesn't feel right, the injections are taken distally. And that's really important when you approach CTOs to have dual access, inject distally so that you're not extending dissection proximally. And ultimately, in this case, what happened is this is actually a reentry technique that was used as well. This is a pilot wire. Oftentimes, people don't want to use hydrophilic wires, but if the point here is just to get distal and then re-enter, in this case, you can use a pilot wire with a knuckle on it to extend the dissection, and then you can actually use this re-entry balloon, the Stingray balloon, to get back in the true lumen. This is an example of that. You're back in the true lumen, and then after that's done, you can salvage the result. This is another CTO case that was attempted, and what this actually employs is a retrograde technique to be able to get out of the situation. And so again, I think one of the things here with dissections, they don't happen frequently, but if you're an advanced CTO operator and know how to do these things, you can actually bail yourself out of some difficult situations. So here, the entire vessel shut down. You can see staining in the vessel here, and so the retrograde approach was used. A collateral was identified. Here you'll see a wire traversing through the collateral and then up into the RCA here. And then, again, you're not injecting proximally or anything like that, but what happens is this is all dissected here. The wire actually, now it's in the true lumen, it easily goes because that vessel was okay, and you saw the wire goes into the guide, which can then be externalized, and then at that point you can actually stent from proximal to distal, and then this is your result that was seen here. And I'll just show you one last case as well. This is another example of a very, very nasty CTO type of case, and this was dissected through a controlled technique using the cross-boss system to go down to here, but again, huge dissection all throughout the right coronary artery. So what do you do in this situation? You actually then can try to re-enter distally. And this is probably, you could try with the Stingray balloon, but you can actually also try with a wire. And in this case, wire actually was able to cross distally, and what was done here is you actually can deliver a second wire using a dual delivery catheter. And so in this case, actually just use a thrombectomy catheter. You take the thrombectomy catheter down through that subintimal plane, you know it's over the wire that's in the true lumen distally, and then what we did here is we actually used the second wire through the thrombectomy port, went out through the side of it, made this side branch stabilized, and by actually hooking up the back of the thrombectomy catheter to a TUI, you can inject. So this injection is actually done distally through the thrombectomy port, and you can see that both wires are in the true lumen at that point. We only injected distally because we were in the true lumen, and then it was actually successfully stented. Now this is just a final little treat, is that after all this is done, what do we see here? Big guide dissection. And so remember, this needs to be stented rapidly. You can't let this delay very long. And in this case, you stent, you leave a couple struts out into the ostium to make sure you're well covered, and this will heal very nicely. You don't have to do TE, you don't have to do CTs or anything like that. So just in conclusion, you know, I was asked to give you 5 trips, but I'll give you more than that. Some of these are redundant on purpose. So number 1, do not further pressurize the coronary artery or extend the event. Don't inject contrast. So number 2, in case you were wondering what number 1 was, there's no more information to be gained by injecting contrast. So if there's one thing to remember, just don't do that until you've truly dilated everything and stented until you know what's going on. If you have an ostial or cusp dissection, leave the wire in place, stabilize that immediately, and make sure that you deal with that before going on and dealing with the rest of the artery. And whenever you're dealing with these complex cases, look proximally, look distally at all times to make sure that everything's okay. Be very attentive to catheter damping, and if you have damping, particularly, we heard the prior session people talking about guideliners and things. The system was acquired by Boston Scientific, and there's 2 devices. There's actually the Cross-Boss, which is basically a device that you spin rapidly to make a subintimal channel, and then you can re-enter with the Stingray Balloon. And it's basically a balloon that is a flattish type of balloon that self-centers against the artery. And there's a lumen on either side. There's 2 holes. And with a wire that has a little bit of a needle on it, you can go and you can see which way you're coming out. And if you go the wrong way, then you come back and you can sting it, just poke it out, and then advance a regular wire, or you can poke it out and advance that Stingray wire, and then once you're down, you can exchange for regular equipment. But basically, it's a way, the Stingray at least, is a way of getting through a subintimal channel, because in the CTO, that's one technique of using. It's different than the Japanese technique of very controlled things. This is less controlled, but it's a way of re-entering when you have that occur. And from what I understand, I think it'll be here very soon.